Right, guys, welcome to another episode of the House of Health podcast. I am your host, Dr. Nadir Abbas. I'm a liver physician, researcher, and work at House of Health and in the NHS. As you know, we bring you cutting-edge topics. We've discussed GLP-1 analogs in our last episode, which was super popular. And today, I thought we'll talk about something that is very in these days. We're talking about regenerative medicine, the fascinating world of regenerative medicine that everyone keeps talking about. We see the buzzwords like anti-aging, anti-senescence, reversing your age. So we thought this episode should be based on all things regenerative medicine. If you're somebody who wants to know more about regenerative medicine, including PRP, stem cell therapy, then this podcast is for you. I've got just the right man as my guest, who is one of the leading experts in regenerative medicine with me. And we're very lucky to have this conversation with him. Dr. Ansar Mahmood, Ansar, thank you very much for coming on the House of Health podcast. I will let you introduce yourself because I'll miss a few of your things. So please go ahead.
Problem. No, absolute pleasure to be here. Nadir, thank you for the invite. I'm a trauma orthopaedic surgeon by background. And I got into regenerative medicine, set up the Academy of Regenerative Medicine and introduced stem cells in the orthopaedic market to the UK about 10 years ago. So I think that's probably enough. I also do research in both the NHS for trauma and regenerative medicine around the world, and I teach all over the place. So it's something that I'm passionate about, and I think it is the future of healthcare. So it'll be an interesting topic to cover, I think, for listeners.
Absolutely. So let's dive straight into it. So let's start with PRP, Platelet Rich Plasma. Again, it's being used for a long time now for various different procedures, has its regenerative abilities. We know it's got platelet-derived growth factors. People use it for hair, skin, joints, many other uses. So tell our viewers the science behind PRP, and then we'll jump on to kind of mechanistic effects of how it works.
Sure. So PRP, Platelet Rich Plasma, as you say, has been around a long time. And actually, when I present this at conferences, there's actually data on it going back to the 1960s and 70s in an early form. They called it something else then. But if you activate platelets are what heal you. And when I'm talking to patients, I actually say to them, this is not a super serum. It doesn't make you bigger, faster, stronger, but it normalizes you. And usually when you've got a problem happening, your body or your cells or that tissue is not behaving normally. And what PRP does is it's a great normalizer. It sends a signal back into any tissue to go back to normal. So if you can achieve normal integrity where you've got abnormality, then you're likely to then push that to a normal position of healing or health. So it's supposed to be putting you back in a normal, healthy position. So tissue integrity is what PRP is designed for. And so when you right from big trauma that I deal with every day, people get smashed in car accidents or sports accidents, etc., through to when you just cut yourself shaving. That little tiny nick that you give yourself, you bleed. The reason it clots is because platelets aggregate in that area and they form a clot. Once they form a clot, that clot then breaks down. That breakdown process releases all the growth factors. And those growth factors tell the tissue in that area, go back to normal. There's a problem here, you need to go back to normal. And that's where your shaving cut heals, right? Disappears. Your body deals with it. So the primary healing response from PRP is to go back to normal, and it's just giving that in an amplified form. So for instance, if we're treating someone with a sports injury or with arthritis of the knee, one of the commonest things we treat, we are putting in enough platelets in the billions, and what the body reads that as is, I need to heal. And people who are dealing, your body has the ability to heal itself anyway. But it has a certain ability, So the way I usually describe it to patients is your body's trying to climb up a hill. It only gets halfway up, and then it slides back down. And it gets halfway up, and it slides back down. And you need to get over the hill. And your healing ability diminishes with age, poor health, etc. And we all age for that reason. There's a uncontrolled inflammatory response, and that happens at every cell, every tissue, every joint, every tendon. Every hair follicle, everything, right? So everything is aging with a degree of controlled aging and inflammation. If you can change the switch a little bit, increase the growth factors and push you up the hill, you can reach a point where actually you've now got the inflammation under control. If you've got it under control, then say it's for arthritis, your symptoms get better. Your pain gets a bit better. It manages for a while.
What is the evidence behind PRP use in arthritis? Because I know a lot of people suffer from it.
Yeah.
People traditionally have gone down the route of injecting steroids, which can result in temporary pain relief, but does have its own side effects. In your opinion, what is the evidence behind PRP injections for treatment like arthritis or pain for arthritis, essentially?
Yeah, this is something I'm passionate about, and I still see. I mean, forget everybody else. The orthopaedic fraternity who deals with a lot of arthritis. I still get regular messages from people saying there's no evidence for it. There's no evidence for it. And they're right and they're wrong. Okay. They're definitely wrong. And they're definitely wrong because there are over 40 level 1 randomized controlled trials showing PRP is beneficial.
Yeah.
There are 5 meta-analyses, which is the highest level of evidence where we combine lots of studies.
Yeah.
We combine lots of studies and analyze the outcome of those studies. And we see whether there's enough evidence for a positive benefit related to the intervention, and in this case, PRP. So 40 RCTs, 5 meta-analyses, all showing positive results. So there's no doubt, and that's actually more than there is for knee replacement and hip replacement.
Yeah.
Okay. So there's no doubt it works. So where's the problem, right? Because there's also quite a lot of randomized control trials showing it doesn't work any better than placebo, so a control. We actually have done our own research in this space, and I published a paper in 2023 with a lot of co-authors from around the world. And what we did was we broke it down by dose.
Yeah.
So we actually separated out the PRP study and said, okay, so there's a bunch that show it doesn't work.
Yeah.
There's a bunch that show it does work. So what's the difference? And when independently people look at this, like NICE, National Institute of Clinical Excellence, has looked at PRP. They've looked at it 3 times, actually. And the first 2 times they said, not enough evidence to show that it works. Second time, not enough evidence to show it works. In 2019, they actually looked at it and actually approved it for knee arthritis. And it's a conditional approval. With NICE, everything's usually conditional.
Does the NHS provide PRP for
it does
the
selectively. It does selectively. So for knee OA, because NICE have said you may use it, they didn't say you should use it. They said you may use it because there's enough evidence to show that it meets their criteria. Remember, NICE's criteria is it works, and it has to work for long enough to meet what they call a quality adjusted life years.
Yeah.
So it's a financial gain.
Absolutely.
Right? It's a financial gain. So they're saying, is the healthcare system here? It's not saying does something work. It's saying, does it work and is it affordable? Yeah. There's 2 questions to it, sides to it. And they actually in 2019 said, actually there's enough evidence now that it meets our quality criteria, but you must use audit, governance, record what you're doing, record the outcomes on your patients. So do a proper audit and governance, which everyone should be doing anyway, right? So as long as you do that, you may use it for knee arthritis. And that's because, as I said, the studies by them were pretty overwhelming. I think they even in their review from memory were quoting over 20 RCTs showing positive benefit, including some meta-analysis. So they said you may use it. So in the NHS, there are hospitals using it, and in fact, our hospital was also using it for knee arthritis, for instance, until fairly recently with budget restraints and the current state of the NHS. They're starting to pull back on services, and that's one of the services that's struggling now.
If a viewer is listening to you and thinks about PRP for knee arthritis, the common questions are: how often do you need to get it done? Who should they be going to? Because there are lots of untrained providers, not doctors who've obviously learned how to do it. And how many sessions would they need? So what do you
So that's one of the big issues here. Is I educate in PRP all around the world, and one of the big questions here is, does it work? And when you say does it work, what you have to remember is when we analyze, we actually took in all the PRP systems into our labs. We've got a PRP lab at the University of Birmingham, and we analyzed the output of the different systems. So there are 20 PRP providers, with companies selling PRP. It's all called PRP or a derivative of PRP. So it has the same name. That's a bit like saying, well, I sell paracetamol or you sell paracetamol.
Yeah.
But in drugs, it's standardized, right? So it's standardized. So you know what dose you're getting. In PRP, when we analyzed it, we found up to a 10 to 20-fold variation in the content of the PRP.
And is that the size or the quality or?
It's dose and its formulation. So some of them have different ingredients, so different quantities of different cells in there. Some have red cells, white cells, what we call leukocytes, different types of cells, as well as the platelets. And all of these generate different types of signals and growth factors.
What about preparation? Does preparation, the way you prepare, makes a difference to
It
the
does.
number
I
and the
mean,
quality?
That's all in the research and development. So when you're manufacturing a PRP product, you have to get it approved as a medical device, you have to prove it produces what you're saying it produces. So the companies who do it and get it graded as a medical device have to have proven that like 95% of the time it produces consistently what they say it produces. So if they say it doubles or triples your platelet count, then they have to have shown that to the CE marking regulators or the FDA in the US, and they have to prove that consistency over 20 analyses, and they have to provide that data, and it can be independently verified by those regulators if they want to. And that's why the system is so different, because they're engineered differently. The tube is different, the content's different, the anticoagulant's different. Some have gel, some have coating.
Centrifuge is different.
Yeah. The centrifuge is actually, it doesn't matter. Okay. Centrifuge is just a G-force generator.
Sure.
So as long as your tube fits inside of a centrifuge, and you know what G-force your tube, so all the R&D, the research and development is actually all in the tubes and the production of what happens in the tube. So all of the R&D goes into that. Yes, the centrifugation is important because it changes what you make. And that's why the companies have to spin these hundreds, if not thousands of times to work out the differences at different speeds. So they've done all that research for you to get what they say is the optimum for that particular tube or that particular product. But what's interesting is at the optimum level here and the optimum level there can be up to 20-fold different.
Right.
And that's like me saying to you, well, you sell paracetamol and I sell paracetamol. We're both trying to sell it to the consumer, but yours has 100 milligrams and mine has 2,000 milligrams.
Yeah.
You know, that's not a comparable product. Yeah. Yet in the research literature, when you look at them, you're comparing PRP to PRP.
Sure. So there's a lot of variability between the types of PRP you do.
And that's why when you're saying how often you have it, one of the things we found is there's a dose-related response, which makes some sense, right? So the higher the dose is, then you often need it less. So traditionally, the way knee arthritis was dealt with, for instance, was you had 3 sessions. So you came back every 1 to 2 weeks and you had 3 injections. And that was based on studies from about 10, 12 years ago where they compared 1 shot to 3 shots and found that 3 lasted longer and gave a better effect. So everybody then started to do 3. What we've more recently in the last 2-3 years found is that actually if you do a super dose shot, a really high dose shot, you can probably achieve the same as 3 with 1. But you need to be able to deliver a minimum high dose. So, you know, in our practice in the UK, and I think we're probably one of the only practitioners that sell PRP by dose. We actually sell it as high dose or super high dose. And so we can modulate PRP, you know, so I'm afraid I'm a real stickler, but I'm also I'm a PRP geek.
It makes absolute sense. You know, if you're giving something, you want it to work. And if it's low quality and the evidence suggests that it's probably not beneficial, then so I do PRP for hair, and I find that, you know, a lot of people would come and, you know, like yourself, I'm sure the price point is higher than what you would find being advertised on high streets. What do you have to say for that? And there's often this question around, we can get it done for, I don't know, I mean, less than what a PRP bottle would cost. So what do you have to say about that?
So what I say to patients is that you know, you always, you know, that there are patients who are always price sensitive, and I get you know, people saying, well, actually, if it's PRP, I can get from there and here. It's called PRP. They both have the same name. They don't understand what the difference is. However, if my PRP is a medical grade device with clinical data showing that it consistently produces the dose I want or the concentration I want with the formulation of cells that I want for a particular problem. And again, what patients need to understand is that a lot of practitioners, in fact, 99%, I would say, and that's a bold statement, but 99% of people using PRP don't know what's in the tube. Okay. And that doesn't mean just on an individual level, because obviously to know exactly what's in it, you'd have to test every single tube. But actually, even knowing what the quantities and variations are within one tube and another, most people don't know. And one of the reasons I got invited to lots of conferences over the last 10 years was because we did that study where I was one of the few doctors, certainly in the UK, that knew what was in everybody else's system. So I could tell you what this one makes and that one makes and that one makes and that one makes and why they're different and what the differences are. And interestingly, even the companies who make them necessarily didn't know that. They know what's in their system, but they don't know what's the difference between everyone else's.
They also all claim that their PRP is the best.
Well, what company is going to sell a product and say, you know, there's a better one out there?
Yeah, that's true.
Do you want to use that one? You know, they all come along and they're all going to say, my product's good. You know, we've got data, it's a good product. And they're not lying by saying that. That's important to say that their product, because even low dose PRP works, right? But it works less reliably, and not for as long, and so less consistency. So if you say even the lower quality PRPs often work for 50% of patients, but it won't give you 80-90% of patients. And that's why some people lose faith in it. I have trained people years ago who said to me, I've been using PRP, but it doesn't work for this. And then I have to ask them, well, what do you mean it doesn't work for this? What are you using? What's the dose? What's the quality? How are you injecting it? The technique's important. How you inject it, where you inject it, all of that matters. So if somebody just come out with a bold statement, it doesn't work for this, I'm like, well, what do you mean? What did you use? And how did you do it? Because both of those things really matter to the outcome. And that's why we teach it, so we teach it all over the place to try and get those consistent 80-90% results. You have to get both of those things right, using the right stuff at the right time and using it correctly yourself, the technique.
Absolutely. Now, when you inject it, firstly, is it painful? How long is the downtime? Because often athletes and people who are into sports would come to you for this. So what's the downtime? What's the recovery like? How long does it take? And how long will the effect last? Do they have to do this regularly then?
Yeah. So that depends on what you're treating, right? So for knee arthritis, that's usually a condition for most people isn't going to go away. Okay, it's not going to disappear. Once you've got it, you've got a disease process, and that's going to progress over time. That is a natural history of arthritis. As you get older and you use it more, it gets a bit worse. What we know about PRP is that it modulates, so it changes the inflammatory profile of the environment of the joint. It calms the cells down. It tries to encourage a healing response, which reduces the inflammation. We now have data, and from research studies, we didn't have that until only about 3 years ago. But previous studies all stopped at 1 year to 2 years maximum. So you didn't really know what happened to people 3 years, 5 years later. And then a few studies came out with longer term data. And we now know that PRP can be disease modifying. By that means it changes the path of the disease. So I can now fairly safely say to patients that your rate of wear of arthritis drops by about 50% if you have PRP. That's the right concentration of PRP done well, but not all PRPs will generate that result, but you can actually change the disease process. But that means you're going to potentially need it again. So, some people will have a really good effect for 12 to 18 months, and that's the average in our practice, 12 to 18 months, and then they'll come, half of them will need to come back and have a repeat treatment. But the advantage over steroids is steroids harm you over time.
Absolutely.
They actually wear your cartilage out quicker and accelerate the rate of arthritic wear, as well as cause a bit of immune suppression and immune modulation in the joint, which is negative. Whereas PRP doesn't. It actually does the opposite to that. It improves the immunity in the joint. It increases the normalization of the cells in that joint, and it protects the joint. So you've got a benefit from having it repeatedly, whereas steroids, you've just got negative accumulation over time. The more you have it, the worse it gets.
Can it delay the need for a knee replacement, hip replacement? I know it's a broad question, but often people who don't want to go for surgery.
The simple answer to that is yes. I mean, that's actually the commonest patient we get. I mean, unfortunately, most of probably 30-40% of the patients we get are told you need a hip or knee replacement. They come and see us and say, can you delay it? If they say to me, can you avoid it altogether? I think that's an unrealistic expectation. Once you're in the stage of arthritis where you need a hip or knee replacement, PRP is not going to fix that problem for you. But if you're at the stage where I don't want surgery yet, so I say to patients, if you want us to delay the surgery by 1 year, 2 years, we can probably achieve that. That's a realistic aim. If it's earlier arthritis, we can delay by 5 years or 10 years, but you're going to end up with it at some point, probably. And I've got patients, I've been doing this for 10 years. So I've got patients who came to me 7-8 years ago and they're still going. They haven't had their knee or their hip replacement. We managed to keep them going with some repeat injections every couple of years. So I've got plenty of those sort of case studies. I know it's not level 1 evidence, but we've got a good case series of patients who we've managed to keep going, who were told 7-8 years ago they needed a hip or knee replacement. So it's achievable. And that to me is a realistic aim. So that is is a nuance of the consultation, right?
Yeah.
So if the patient comes in, they've got a completely burnt out joint and they say, look, I want a permanent solution to this. I say, go and have your replacement.
Yeah.
The injection is not going to give you.
Not going to work.
Yeah, that's an unrealistic expectation. Whereas if they just say, I'm happy to have the replacement, but not till next year or 2 years' time, because of life, my health, whatever, I had a patient last week who said, I want my autistic child to graduate from university first and then
Think about it.
Then think about it. I just want 1 year. That's something that's realistic. Yeah, we can buy you time, certainly. And even with end-stage arthritis, we didn't used to treat that initially. When we first started doing these treatments, we thought earlier arthritis, mild to moderate, you can have. If you're severe, you need a replacement.
Yeah.
And we didn't used to treat them because there wasn't much data in that. Everyone does it in early to moderate.
Yeah.
Nobody used to do these ortho-biologic treatments in late. And then a few papers came out in the late group showing actually it helps them. And then I did a few patients. And my first grade 4 patients, the advanced arthritis, were a doctor and a nurse.
Yeah.
And it's because they sort of insisted. They said to me, you're saying to me, I remember the conversation very vividly where they said to me, so you're saying I can't have it. Why can't I have it again? I said, well, it's probably not going to work. And they said, yeah, but that's my choice.
Yeah.
And that's how they put it to me. They were medical. They understood. They said, like, what risk is it? I said, well, the risk is minimal.
Yeah.
You have a tiny risk of infection, tiny risk of complications, like 1 in 10,000.
Yeah.
A 1 or 2% risk that your symptoms are going to be worse for a little while.
Yeah.
And that's it, right? There's no, it's just an injection.
And that's the beauty about regenerative medicine. You can, if a person wants it,
the risk profile is very low
compared
to, say, surgery, which was the alternative. And they both said to me, I don't want surgery yet.
Absolutely.
We're in a time in our career. The nurse had just retired.
Yeah.
And she said, look, I've just retired from the NHS after 40 years. I do not want to go and have a knee replacement now.
Yeah.
In 2-3 years, I might be ready, but I don't want to do it now. I want to enjoy my retirement. I want to walk my dogs. And I just want a couple of years where I'm happy and not worrying about major surgery. And I said, fine, that's a realistic expectation. But actually I said to her, but you've got end stage and we're not treating that yet. So I actually went and spoke to my colleagues. We have an MDT, a multidisciplinary team. And I said to them, they've given me a very good argument for treating them. And I don't have a good reason not to treat them, other than we're saying we don't like to treat grade 4. And actually my colleagues went, well, you're right. They've given us a good argument. We don't have a strong reason to not do it. And as long as they accept the risk of
that it doesn't work.
It doesn't work.
Yeah.
And actually there was data by then showing it does work in grade 4 arthritis. Yeah. So we did it. And actually both had very good results. We were both happy. The nurse got a year before she had a repeat injection. And the doctor, interestingly, he was quite advanced. And he got maybe 6 to 9 months. And he still had a significant limp. But what I remember him telling me was he was no longer on drugs and he was sleeping at night. And that was really important to him, not to sleep.
Yeah.
Night pain is miserable. So even though he was limping around, because, he had some slight deformity, he had a varus knee. So he had that classic sort of look of him where I would normally say, no, you can't have it.
Yeah.
There's no point. But then he said, well, I'm happy. If I can get off the drugs and sleep at night for 6 to 9 months, I'll have it every 6 to 9 months until I have my knee replacement. And I'm not ready yet, but I might do that in 2 or 3 years. And that's a realistic expectation. And so we can sort of meet that a lot of the time.
Absolutely.
So those are our sort of classic patients, I suppose. They're not ready, they're not suitable.
Yeah.
And or life stops them.
Yeah, personal choice.
Surgery. It's personal choice.
Absolutely. Yeah. Now let's talk about stem cells. Okay. Yeah. There's a lot of hoo-ha. Everyone's talking about it. We know that stem cells in the medical world have been there for decades, right? We've been using it for, hematopoietic stem cells have been there for, transplant for leukemia, lymphoma. Bone marrow transplants. We've also used it for various other conditions. But recently, there's been a lot of discussion around anti-aging effects of stem cells. We know celebrities are flying from different areas to the world, trying to get stem cells, and some people vouch for it. We know that there is the strong evidence behind anti-aging still lacks. But let's talk a bit about stem cells, what your take on it is. What are the kind of regulations in the UK? Can people just get stem cells from anywhere? If they can, what kind of stem cells are there that are available? And let's just dive straight into it.
Yes, yeah. Stem cell game it is a difficult one. We obviously I'm a believer in stem cells. The potential they have, what we call in vitro in a laboratory, is enormous. Right, we can get them to do lots of things, make lots of cells, reverse and improve cell function. So the anti-aging property in a laboratory almost seems infinite. However, in life, we're putting them into patients, and the way your body reacts to a cell is very variable. What the regulators are worried about is that when somebody's got cancer, you've got leukemia and you have a stem cell transplant, you've got a life life-altering disease or a life-ending disease. So if you then have a stem cell transplant, the risks associated with it are fairly high, but actually they're outweighed by the fact you've got a disease that's going to potentially kill you anyway. And so that balance is in the patient's favor. Whereas if you're having it, say, for knee arthritis or anti-aging, people have them as infusions. What if you've got some abnormal cells in your body, and these cells, which can be uncontrolled in the way they function, they get a hold of abnormal cells. By abnormal cells, I mean cells that are functioning abnormally already. Some of them is maybe precancerous, and the growth factors and the stem cell driver on those cells may accelerate that deterioration and create a new cancer. And that's what the regulators are all afraid of. They're afraid of what we call tumorigenesis, generating tumors. And that's why they've strictly regulated this space for quite a long time. And what we know is that if you don't manipulate cells, so if I take your cells, whether it's from bone marrow or fat, we can have a debate about fat or bone marrow. In Europe, fat has become the biggest source of stem cells because there was quite a lot of research from over 20 years ago now showing that there are cells within fat which are very stem cell rich, and they hold a lot of stem cells. So the quantity of stem cells is quite high within fat. They're different stem cells from bone, and you get less from bone by quantity, but they do work differently. And actually, when you compare studies, say for arthritis using bone marrow or fat derived, there's actually not that much difference. They seem to work effectively. So it's not just about the number.
Yeah.
The sizes and everything, as they say. But people get obsessed with cell counts. But I think the cells that people are having as infusions usually are not their own. Sometimes they can be. So I can take your cells, whether they're blood, fat, or bone, and I can take them to a laboratory. And in a laboratory, I can expand them.
Yeah.
So you can make one cell make two make four. That's what, we know that classic expansion process. To do that, you have to turn the airbags and brakes off a cell. Okay, you have to give it permission to just grow. And that's what the regulators are worried about. And that's why currently in the UK, you're not allowed to expand cells and then give them back to a patient, except in certain medical conditions as an advanced therapeutic medicinal product. So there are certain conditions and licenses and so a lot of control over that area. Whereas minimally manipulated cells, if I take your cells, concentrate them, I don't turn the brakes or the airbags off, so their normal control mechanisms are in place, and I concentrate them, clean them, don't fiddle with any of their control mechanisms, then put them back into you. And these are what we call mesenchymal stem cells. They work normally, and your body can control them, and they still have the control. So if something is abnormal, they'll die and disappear, and your body knows what to do with those cells because they're from itself.
Yeah.
Those are allowed. Those are currently allowed in the UK and most of Europe. But somebody else's cells that have been expanded, there's a lot of regulation around it. So you can get them, but currently you've usually got to get outside of the UK and even outside of the European Union. And that's where, even in the US, they're not allowed in the US. So in the US, I've got friends who've been treated and they go and have a shoulder injection in the US, and then they have to get on a plane and go to Panama or Colombia for the intravenous cells, for the anti-aging or the systemic effects.
More celebrities flying to Mexico and all these places to get
so
them
there
done.
are a lot of countries, and there is my worry around. I've never recommended a client to go abroad and have these cells. One, because I'm not there. I don't know the quality. I don't know what's being produced and the regular. And so you have to remember all these places produce cells differently.
Yeah,
they use different cell sources. And I'm not saying they're doing them badly. I think some of them are doing them very well, but they have very minimal data. Because actually, if all these clinics really had cured 2,000 people's Alzheimer's, they'd have published it.
Yeah.
Right. Our data we've publicly put out. I've been to conferences and presented our data, so people can analyze it, criticize it. We've published some of it, so we know what our success rates are. And if I had cured 2,000 people's Alzheimer's, I'm telling you, it would be published everywhere. It would be published everywhere.
New England Journal of Medicine.
Exactly. Yeah. I would be at every conference in the world telling people what to do to sort out Alzheimer's. Yeah. And that's where the issue is that I have with this space is that unrealistic claims. And we don't know yet. There is no good data showing that if you have a stem cell infusion of somebody else's umbilical cord or baby derived, these are waste products, and people have an ethical issue on saying, using baby cells. They're not baby cells. These, when a baby's born, the placenta, the Wharton's jelly, the amniotic fluid, and the umbilical
they're
cord,
thrown away.
binned, right?
They're thrown away. Yeah, given to the cats.
Yeah, exactly. These are binned.
Yeah.
So this is tissue that's going to go in the bin. So to use the cells from that for something useful actually is a very good use of that tissue. So there are companies around the world who harvest these cells and then make sure they're clean, make sure that they don't have any viruses or any abnormalities, and then they use the healthy ones that they quantify to generate more cells. And as long as it's done in a GMP facility, so good manufacturing processes, there's a regulated process that's internationally accepted for generating cells. If they meet that criteria, then they're producing good quality cells. But there are nuances to that, So some of them will go, for instance, they let a cell expand 4 times only and stop, because we know that each time a cell separates, its DNA and its RNA and its quality diminishes slightly. And some people will say, well, once you get to 4 cycles, you start to get abnormal cells.
Yeah.
And so some companies' cells, and that's where the nuance comes in, right? You don't know what everyone's doing. So some people only go to 4 cycles and stop. And hence, but they'll actually then have a smaller cell count. They'll often say to you, well, I can only make 1 million cells or 20 million cells. Whereas others, you'll suddenly see, they'll say, oh, I'll give you 100 million or 200 million cells. And you think, well, how are they doing that? Yeah. So are they just better? Or actually, are they going to 7 cycles, 8 cycles, so replications, and hence they're accepting half their cells are potentially not so great.
Yeah.
And that's where, if you don't know that, and I don't know that, which is why I don't say to patients, go to this centre abroad, because I'm not involved in that process.
This is the trouble with a lot of, especially this space where, this has been taken over by non-medical professionals, people who have false claims like this systemic cell type therapy would, reverse your aging, you'll become anti-human and, you'll never die. And this is one of the issues, we as a medical fraternity have with, people claiming without any medical background. They seem to be, fitfluencers, as I call them, spreading misinformation.
Yeah, and I get people may feel better, but there's 2 issues with regulation. Regulation is there to try and protect people, so it's important we have it. But I think if regulation becomes a brake to innovation, it's stopping us innovating and learning, then the balance may not be correct.
Yeah,
and so, for instance, like in Japan, Italy, I think they have better regulatory profiles where they actually say, if you make something and you think there's an innovation that's positive for health, you just have to prove it's safe. If you prove it's safe, we'll let you use it. Okay, you don't have to prove it works. Okay, you don't have to prove it works, because to prove it works, you need a big randomized controlled trial, hundreds of patients.
How do you prove it's safe, though? How would you prove system? I mean, so if you don't have long-term data,
the way they prove safety is that it depends on the disease profile, right? So if you're, say, treating arthritis, that if you treat somebody, if I just invented a stem cell for the knee or PRP for the knee, if I put that in 50 to 100 patients, and remember, this is a predicate product, right? So what we mean is there's already existing data on it. So this is a product that's from people, as long as you can make it clean and you can inject it back into the knee safely, it's not likely to cause harm. You already know that, but your presumption is, I just need to prove that. So you then run a study on consented patients, 50 to 100 patients, and you follow them up for 6 to 12 months. Okay,
so it's clinical trial data.
It's a clinical trial data. It's what we call a pilot data. To prove safety, not efficacy.
Yeah.
And then so they'll do that. 50 to 100 patients. Most even small companies can afford that, so they'll do that trial data. So they have to present data, and then they'll say it's safe. We've shown it's safe. It's no worse than steroid or any other treatment out there. We know it's safe. We don't know what the long-term data is because we haven't done that study, and we can't afford to do 1,000-patient randomized controlled trial. And so the regulators will then look at that and say, you're right, you've proven it's safe. Now use it.
Yeah.
And then collect the data.
Then it goes to efficacy.
Exactly.
And
so then once you've done it in 1,000 patients, who are all consented and obviously the appropriate processes, and that's why Japan has 200 plus stem cell clinics that are government approved and authorized and regulated. Because they've got data showing that the product was safe. They were allowed to open and run data as long as they're collecting it and sending it back to the government. So the government then gets, within a year or two, they get data showing that this is working, that's not working. They can actually then make sensible decisions and say, stop using that because it's not working.
Yeah.
Right. So there's no efficacy data on this. It's just not working. You all need to stop using it. And you can actually regulate things in a more tuned way, which I think is intelligent. But it doesn't stop innovation either. People can come up with a good idea and say, well, actually, this does work and I've proven it's safe. I don't know if 100% if it's going to work long term, but we're going to try that. To me, that's the right balance. Whereas I don't think we've got it right, because to demand a level 3 clinical study in everything that you're going to put in patients means you have to have sometimes somewhere between 5 million and 50 million pounds in the bank to even get started on a product. And that means you almost close the market off to anyone other than big pharma.
Yeah.
The only people with that kind of capital to take a punt on a guess. It's a guess at the end of the day. We think this is going to work. We don't know.
Yeah.
We're going to prove it with a big trial, so we have to put 5 to 10 million pounds just to get it off the ground, and maybe 50 million by the time we've got all the trials done. It's really difficult, and it means you close off all the small companies that are innovating and thinking, all those scientists out there doing great work. Yeah. They just can't afford to prove that it works.
Let's talk about your own practice. So in your practice, if someone's looking into, things like PRP, stem cell, for, injury prevention or, treatment of their kind of injuries, or what do you do and where do you do it and how can people get in touch?
Yeah, so obviously I work at House of Health as well, so they can get in touch there. My own clinical regeneration business is called Kaizen.
Yeah.
Kaizen's from the Japanese. It's 2 words, Kai and Zen, which means perpetual improvement or continuously, improvement. So Kai and Zen. So we like that. Life is about incremental benefits. You don't usually do one thing that suddenly makes you so much better. You've got to do lots of small improvements in lots of different things to get better. And that's manageable for people. If you suddenly say to people, I want you to just stop doing this. That's why fad diets don't work, right? So you suddenly say to people, just eat, I'm on a carnivore diet. How long are you going to maintain that for, right? So it gives you a bit of a boost for a little while, and then everyone crashes and relapses, which is what the data suggests. So you've got to give someone things they can manage. So small incremental improvements most people can manage. They're sustainable. And that's our philosophy. And I think with PRP and stem cell, what I always start with is I usually say to the patient first, what is it that you're after? And what do you think we can do for you? Because often they've been on Google and they've watched some stem cells rebuild a knee on a video, and they think, these guys can get rid of my arthritis.
Yeah.
And so I have to re-engineer that thought process first. I say to them, well, this is what they actually do. They don't actually regenerate your knee. They're going to reduce the inflammation. Most of them do an anti-inflammatory or immune modulatory. They modify the way your own cells are working. They change signals, and then they disappear. Okay, so they're reprogramming, but they're not rebuilding. So those Google videos of cells rebuilding and replicating your cartilage doesn't really happen.
Yeah.
Outside of very young patients, we've all seen regeneration. People in the regenerative medicine game, we've all got an MRI scan of somebody whose knee cartilage is recovered.
Yeah.
I've got those. Right? So I technically, I'll go to a conference and put up an MRI scan and show you someone I've regenerated. But I don't know who's going to happen in.
Yeah.
Okay. And it might happen in 10 or 20% of your patients. And what I've noticed is it happens in those younger patients who have better biology. They've had an injury and then they get a accelerated arthritic wear. You manage to turn that off and by reducing the biological insult in the knee. So there are interleukins, we're getting a bit geeky now, but there are cells in your knee that once you injure the knee, say for instance, we always talk about knee because that's 70% of our patients. But if you injure your knee playing football at 20, you actually then start a degradation process, which, I think the future of this space is how do you identify someone that's going to have arthritis in 20 years' time? Right?
And how do you prevent that?
And how do you prevent that? And what's interesting is that, there are already blood tests out there that companies are testing. There was something published in Nature from, I think, Cambridge University about 4 or 5 years ago where they said we've got a blood test where we think that once you actually damage your cartilage early on, we can measure a change in blood that will tell us. Those aren't widely available yet, but they're becoming online. So the way I see the future of this space is that if a 20-year-old hits their knee in football, the knee becomes painful and sore for a few weeks. If it calms back down, you can check a blood test on that patient, and you can measure this protein or whatever molecule that may be there, RNA that's appeared from an injury. If that returns to normal, then their risk of arthritis is no higher than anyone else's. But actually, in some patients, it doesn't. Okay, so it will stay high because now they've kicked off a biological cascade in the knee that's creating an ongoing wear and tear response in the knee. And that biological signal we can already turn off. PRP can turn it off. Stem cells can turn it off. We already have products now that we can turn that off with. interleukin-1 receptor antagonists those are widely available already, and that's one of the primary signals that generates this wear and tear ongoing response. So I say the future of this space is you have a blood test. In 3 months' time or 6 months' time, you repeat the blood test. If that's still high, you get the injection now.
Yeah.
When you're 20, you don't get it when you're 45 and your knee's already knackered.
Absolutely. Prevention.
Prevention, right? So we turn it off now, and then we repeat that blood test in 6 months, 12 months, and hopefully it's gone. If that signal is then gone, then you've protected your knee from the problem it's potentially going to have. And that's the future of this space.
Yeah. Talking a bit more about Kaizen, tell us, what else does Kaizen entail? You talked about the longevity space, and you're pioneering the research, and not only research.
Yeah, so longevity medicine is something. We call our programs longevity as well, right? And those are available, with House of Health. But I find longevity irritating. Remember, I'm a trauma surgeon, and I know that you can live as healthy as you like, and you can get run over by a car crossing the road.
Yeah.
So longevity is no guarantee for anybody. But what you actually want to do is you want to live optimally, right? You want the best health you can for as long as you can. Because, one of the things we know is that people are living longer, but actually their health is deteriorating earlier. So if you're ill from 50 to 80, that's 30 years of your life for a chore. They no longer become a pleasure. So really, if you're going to live to 80, 85, the average life expectancy for a woman in the UK now born today is 90 plus, right? So, and if you're in good health, you can easily, already people are being born now, potentially live to 100. We know there are lots of health challenges with all of that because of obesity, environmental pollutants, cancer rates, everything seems to be going up. But actually, people are living longer. Despite all these environmental issues, they're living longer. And if you're living longer, you want to be as healthy as long. So an optimal, what I prefer to call it health span medicine, but it's not sexy. Everyone likes to call it longevity medicine. So we have programs, and I think where we came at this was a unique angle, because when I introduced stem cells in the first few years, our journey was all about the juice. How good a stem cell juice can I make? How good a PRP juice can I make to optimize the results for the patient? But then, once you've been doing that for 2 or 3 years, you realize the elephant in the room is the patient, right? So if their biology is poor, their diet's poor, their health's poor, if you don't optimize that, you're taking the biology from them and putting it back into a poor biological generator. So you need to sort of fix the patient. So then we actually got into the game of what we call preparing the soil. And just like farmers prepare the soil, they don't just throw seeds on hard, dry, impacted. They fertilize it, they furrow it, they take the tractor out there, they get the soil, and then they put their seeds in, because then they expect a response, and then they water it and nurture it. And the human body is no different. So we now have programs where we optimize your health first. Anti-inflammatory diets, supplementation, genetic testing to see what your metabolomic profile is, what you absorb, don't absorb, what you respond to and don't respond to. We then match that to a blood test, because genetics only give you a trend or a pattern. They don't tell you what's actually going on in you.
Yeah.
Right. So you can have, I had a poor guy who came to me not long ago, and he told me that he had a genetic test which showed him that his B12 absorption ability was low. Yeah. And the counsellor he spoke to recommended he start taking B12 supplementation. And so he started taking B12, and he came to me saying, I don't feel well, I feel worse. And I said to him, well, has anybody actually checked your B12? And he said, well, no, but they told me to start supplementing because I don't absorb. And I said to him, but with that particular genomic profile you have, 80% of patients don't absorb as well as others. That's what it means. It doesn't mean you don't absorb. So let's just check your B12. And I checked it, and he was 10 times above normal range. Yeah. He was poisoning himself with B12 because he was taking huge doses of it. And that's why he's feeling worse, not better. There's a price to pay. There is such a thing as too much of a good thing. And I always say that to patients. We have to balance you. Your body is designed a certain way, and too much of something, actually, it has to modify that. And by modifying that, it actually generates more inflammation, or it presents a challenge to the body that it doesn't need. And actually, you're now compromising other systems because you've got too much of this thing there. So we always do it in balance. To me, our crux in Kaizen is precision, personalized medicine. It has to be precise, it has to be personalized to you, and we do it medically. We understand physiology, and we measure everything we can, and I think probably we're the most measuring medical practice in the country. We do scans, analysis, we try to work oxidative stress levels, we do cellular genetic testing, we try and link all that together, and no one does this perfectly anyway, because we don't understand it that well yet. There's like 2 million different genomic sequences out there that we don't understand. We probably know what half of them do at the moment. So nobody can do a genetic test on you and say, oh, this is your problem, this is what you need to do, unless it's only about one specific thing. They might say you got...
This is increasingly common. People do come in with a genetic test, and exactly like you said, they say, oh, we can't absorb folate. And then they'll start taking supplementation. But this is where detailed blood testing comes
absolutely,
in.
Yeah. You can match
and you have to look at everything as a whole rather than just
absolutely.
one thing.
And what you can optimize is what's important. You can optimize lots of things. And as I said, that's sustainable. So you can change supplementation. Obviously, that's one. You can actually correct their levels to an optimal level. Because there's a normal range. We know in medicine, there's a normal range. It's between this and this. What's the optimal range? Like, we don't even think of that, right? We're both doctors in a hospital. We're both specialists. And as long as the patient falls in that range, we go, oh, you're fine.
Yeah.
Right? But the patient's like, yeah, but I've got symptoms. And nothing in the NHS teaches you what's optimal, right? It's just that you're in the normal range. So you must be okay. But no, but I've got symptoms. I saw a patient recently with thyroid, all the symptoms of hypothyroidism, right? Fatigue, tiredness, hair loss, everything I could see. But a blood test was borderline. So the GP was like, well, we'll just repeat it in 6 months. And I said to them, there's not a private endocrinology clinic in the world you'll go to that won't treat you. Yes. You've got every symptom. But because the computer says no,
absolutely,
they're not addressing the thyroid
thresholds
problem.
at the NHS will also, like for example, being a gastroenterologist, we look at ferritin levels, and our deficiency is extremely low. And we still find that if you are above that threshold, you'll still have hair loss, you'll still feel tired. So optimization is something we at House of Health are very passionate about, whether it's vitamin D, B12, other things. It's important to check first of all and then get it optimized for optimal
And the key
health.
here is the optimal level is going to be different for each patient. It's not saying, well, this is the level. You know that 50 to 100 may be the range. 75 to 90 is maybe optimal in males, but 70 to 80 may be in females. And those are the kind of studies we really need.
And then age group as well. For somebody who's 20 and 60 have different thresholds.
Yeah, absolutely.
Fantastic. Now, that's I think that was absolute masterclass on regenerative medicine. We really enjoyed it.
We're only just touching it.
Just setting it. I'm sure we'll do more episodes. And one of the things that we'll mention in the bottom of the podcast is any questions that people would want to answer. I know we did it quite impromptu, so we weren't able to get questions from viewers, but I'm sure we'll have lots of questions. And hopefully we can do another episode on some stuff.
To it.
Dr. Ansar Mahmood will be working with us at House of Health. As you know, we're very passionate about regenerative medicine, longevity. That's the sexy word. And no one better than him, joining us for in this sphere. So absolutely, you can get in touch with us through House of Health, and we'll also mention his credentials at the bottom of this video. I hope you found it helpful. For more such videos, like and subscribe, comment, and I'll see you in another episode at the House of Health podcast. Thank you very much for listening.